empty room மாதிரி இருக்கு. I won't point out anyone. I'll just raise questions. If anybody can answer, whatever they speak, that will get recorded. Huh? That's also a problem. They will not be focused, no? Persons who are known to me has to sit in the front. Persons known to me has to sit in the front so that it's easy for me to ask questions. We'll start. Okay. Anybody is there after 2:30?
Some of them go back.
Yeah. Okay, sure.
I'll just start. Good afternoon, everyone. Welcome to the Department of Medicine teaching lecture series. From today onwards, we are starting our series on cardiology. And we have Dr. Sakthivel Selvaraj today with us, who is an assistant professor in the Department of Cardiology. He is here to give us a talk on hypertension, diagnosis and management. Thank you so much for taking your time.
Good evening to everyone. So today, pulmonary hypertension per se is a very big topic, and it's very difficult to concise everything in an hour talk. So I have just focused mainly on how do we proceed to our diagnosis in our day-to-day practice, and I focus mainly on class 1 pulmonary hypertension and a few slides for each groups, how to treat them and manage and treat them. So pulmonary hypertension is a condition characterized by increased pulmonary artery pressure. When I say it's increased pulmonary artery pressure, it's mainly mean pulmonary artery pressure. So mean pulmonary artery pressure is basically a right heart catheterization study. You don't need to write down anything because it's all from ESC 2022 guidelines and textbook of Brownwall textbook. So you can go through and read those things. So when I say mean pulmonary artery pressure, it is mainly a right heart catheterization study. And how are we going to extrapolate it to our clinical findings and ECG, echocardiography is what we are going to see in our diagnosis part. So WHO basically classifies into group 1 to 5. And just briefly about the pathogenesis of pulmonary hypertension, I hope you could see this slides. So it's for a class 1 pulmonary hypertension, it's mainly a genetic basis in some cases, and some cases it's idiopathic, and some cases it's because of drugs. So it comprises of idiopathic, drugs, and heritable causes. So that is one of the important class of pulmonary hypertension. If you can see, it is mainly by the environmental triggers. The classical drugs that were incriminated in pulmonary hypertension were the fenfluramines, anorexic agents, and then drugs like methamphetamine, which is not very uncommon nowadays. We see many places where they find out methamphetamine use, or we are yet to see those populations. So there can be some dormant people having these things which are not coming up to the clinical presentation. So infections like HIV, which is one of 0.45% of patients with HIV can present with pulmonary hypertension. Other features like systemic inflammation, where as a part of a systemic inflammation, pulmonary vasoconstriction, inflammation, and thrombosis can happen in specific conditions, ultimately resulting in endothelial dysfunction of the pulmonary vasculature and excessive proliferation of muscular smooth muscles, causing vasoconstriction and vascular obstruction, and dedifferentiation of the fibroblast in the adventitia, causing fibrosis in vascular stiffening. At the end point, the RV gets uncoupled from the pulmonary artery. The pressure difference, the RV is not able to cope up with the rise in the pulmonary artery pressure, resulting in RV pulmonary artery uncoupling and ultimately culminating in RV failure and profound right heart failure. Recent evidences are there, which is noted, actually it's quoted in Brownwall only, you can go through and see. Increased sympathetic nervous system activation is also found out in pulmonary vasculature as a cause of, and it's incriminated as a cause of, one of the autocoid causes of pulmonary hypertension, and where ARNIs are even being tried in pulmonary hypertension with futile responses. If you can see in this slide, the RV cardiac output remains stable till the end stage of pulmonary hypertension. If you can see, if you rely on RV function for the treatment of pulmonary hypertension, it is very spurious, because till the patient goes in for the advanced stage heart failure, the cardiac output remains the same. And then once uncoupling happens and there is no turning back, and ultimately the patient will spiral down for heart failure and death. You can see the histology also changes drastically from normal muscular architecture to increased proliferation of the vascular smooth muscles and extensive infiltration with the mononuclear cells. resulting in vascular obstruction and proliferation of those vascular smooth muscles, resulting in vascular obstruction. So the key here I wanted to emphasize is to pick up this patient at the earliest stage, find out the underlying causes which predisposes them for pulmonary hypertension or prevent them from progressive pulmonary hypertension, protect them from vascular changes, so that you can have a good prognosis in these conditions. So 1 to 2% of is the prevalence of pulmonary hypertension in general population. As pulmonary, as you can see here, mortality hazard ratio increases as mean pulmonary artery pressure and the pulmonary vascular resistance increases. This is the clinical classification by WHO. Class 1 is called as pulmonary arterial hypertension. Rest of the conditions are called as pulmonary hypertension. If you note down closely our echo reports, where we see if a patient has a mitral stenosis, we will use to write as pulmonary hypertension. If a patient, classically a young female presenting with pulmonary hypertension with no shunt lesions, no left heart failure features, no lung diseases, idiopathic pulmonary hypertension, we used to write as pulmonary arterial hypertension. So just based on this classification, there are so many modifications, but essentially the 5 class remains the same. If you can see here, so the left heart diseases are the most common conditions. Left heart diseases are the most common conditions that we encounter in our day-to-day practice. You would see at least 1 or 2 cases of valvular heart diseases presenting with advanced or early stage of pulmonary hypertension OPD. And pulmonary arterial hypertension is one of the conditions, but it is one of the rare conditions. We don't get these patients very often, but these are the patients where there is a good number of drugs that are available for us to treat those patients. So rest of the conditions where group 3, group 4, group 5 is basically treatment of the baseline condition. Like if for a group 3, it is a treatment of ILD. If a group 4, it's a treatment of underlying causes. So basically, classically, from the beginning, pulmonary arterial hypertension means it's a class 1 group. Now rest of the conditions are non-PH conditions. Clinical class 1, as we have discussed before, includes idiopathic, heritable, and drug or toxin induced. Classical, as you have seen from our UG days, we used to see this fenfluramine from age-old days when they were started to used for weight reduction therapy. They caused pulmonary hypertension. So these are the definitive drugs that are associated with pulmonary hypertension. Methamphetamine, nowadays we see many drug seizing things happening with methamphetamine. So as we discussed, we are yet to see this population. Dasatinib, I have recently started seeing some patients with dasatinib induced pulmonary hypertension. They present 2-3 patients I have seen from this. Then I went back and studied about this. This dasatinib is one of the commonly used drugs in oncology which can cause pulmonary hypertension. Classically, they present with pulmonary vascular changes, pleural effusion, pulmonary hypertension, and some cardiotoxic effects. So, if the patient is not presenting with severe pulmonary hypertension, it is good to stop the medication, not to restart the medication. Follow them up for 3 to 4 months. If it's resolving, it's good. If it's not resolving, then we have to sort out to do a right heart catheterization, find out these things, and start treating them with medications. So it essentially falls into class 1. Alkylating agents, cyclophosphamide is one of the commonly used drug in many departments. If a patient presents with pulmonary hypertension with the history of significant use of cyclophosphamide, we have to think of pulmonary veno-occlusive diseases. It is notorious to cause those diseases, those disease. But other drugs like cocaine, leflunomide, cocaine we don't see often, but leflunomide we see many patients from rheumatoid arthritis using leflunomide. Moving on to hemodynamic definition of pulmonary hypertension. Pulmonary hypertension, from the beginning, the definition is mainly based on right heart catheterization. Pulmonary hypertension is defined as mean pulmonary artery pressure more than 20. You would have seen more than 25 some 2 years back. The initial recommendation was more than 2015 ESC definition was more than 25 mean pulmonary artery pressure. They diagnosed pulmonary hypertension. Now it's 20. And the pulmonary vascular resistance, initially it used to be more than 3 Woods unit. Now it is to be 2 Woods unit. It's basically a capillary and post-capillary. There is a capillary in the lung, and post-capillary is towards the heart, pre-capillary is towards the lung. So pulmonary arterial hypertension is mainly in the pre-capillary. So whatever post-capillary happens, it happens in beyond the capillaries, either in the pulmonary venous occlusive diseases or in the left heart system. Left heart system essentially can have raised LVDP, which can back transmit into the pulmonary circulation, resulting in the pulmonary hypertension. Those cases comes under the class 2 groups. Valvular heart diseases can cause, like mitral stenosis, can cause pulmonary venous congestion, venous hypertension, resulting in long-standing cases can have pulmonary arterial changes also. Essentially, in the early stages, group 2 cases will have a pulmonary venous hypertension that will have reactive pulmonary arterial hypertension. If those cases are not treated in the early stages, the persistently raised pulmonary pressure in the pulmonary artery can lead on to vascular changes. That's why there is a gross difference in pulmonary arterial response to treatment in a young patient who presents with mitral stenosis than an age-old patient like 40-50 years who presents with pulmonary hypertension. We tend to see treating catheter-based interventions for mitral stenosis in a younger individual. There will be a good response for pulmonary hypertension, because most of those changes that happen in the pulmonary artery is basically a reactive changes in the young age group, early stages. But if those things are left untreated for 40 years, up to 40 years, 45 years, there is some component of pulmonary arterial changes that happens in those patients. Even after the successful treatment of valvular heart disease, those conditions remains the same. So it doesn't come down to the baseline. So that again, I want to emphasize those things has to be treated very early. Definitive therapy has to be given for all those conditions to prevent the progression of pulmonary arterial hypertension in those. So it can be divided into pre-capillary. Pre-capillary means essentially in the pulmonary artery, the mean pulmonary artery pressure will be more than 20, and the vascular changes would have always happened. It is more than 2 Woods unit. But if you mean the pulmonary artery wedge pressure, which is essentially a venous pressure or the left-sided heart pressure, remains less. It is less than 50 millimeter in a isolated pre-capillary pulmonary hypertension, essentially a pulmonary arterial idiopathic pulmonary arterial hypertension. Isolated post-capillary pulmonary hypertension would say in the early stages of valvular heart diseases, where there is isolated post-capillary pulmonary hypertension only because of post-capillary. Beyond the capillaries, there is pulmonary venous hypertension, or the left-sided pressures are very high, which can back transmit and reflect as a pulmonary arterial hypertension. Once you treat that, those pressures will come down. So those patients will have mean pulmonary artery pressure more than 20. PVR will be less than 2. Again, PVR, when it goes more than 2, so in the, which it becomes the isolated post capillary becomes a combined post and pre-capillary. Of course, there are separate conditions for each class. I just want to emphasize all those common cases that we see in our day-to-day practice. To move on to the symptoms, fortunately, unfortunately, we have very few number of symptoms. For a cardiac case, it will be a dyspnea, chest pain, palpitation, or syncope. But if you have a suspicion of a pulmonary hypertension, dyspnea on exertion is the most common symptom. In fact, dyspnea in a middle-aged adult, only presenting with dyspnea will be a diagnostic enema for most of us. We will not find much in the ECG or echo, and people will keep shuttling between pulmo and cardio. So when you think of pulmonary hypertension, dyspnea on exertion, bendopnea, fatigue, EC fatigability are the most common manifestation with which the patient presents to you with. At advanced stages, atrial arrhythmias can happen, so that, or in the early stages itself, the patient can have exertional palpitations. Advanced stages, arrhythmias can cause palpitations, and hemoptysis, weight gain due to fluid retention, syncope, or those where the disease has progressed to beyond repair. Late stages, when a said patient with pulmonary hypertension presents to you with exertional chest pain, typically we have seen some patients, some interventions also are done in those patients. Those patients had dynamic compression of left main artery. And compression can happen for the recurrent laryngeal nerve, causing Ortner syndrome, or it can cause compression in the bronchi and resulting in recurrent respiratory tract infections. So after knowing the symptoms, how do we clinically, what are the things that we look for diagnosing a pulmonary hypertension? Per se, if you see, not these signs that we are going to discuss will not be seen in isolated patients. So those patients will have other valvular heart disease, will present with pulmonary hypertension, where you look for severity of pulmonary hypertension. I hope you get me. Like if a patient with pulmonary mitral stenosis, then you'll be intrigued to find out clinically how the patient has a mild pulmonary hypertension or moderate or severe pulmonary hypertension. So if you see here, when you think of pulmonary hypertension, first thing comes to your mind is loud P2. So I would like to ask how you qualify a P2 as a loud. So basically, to start with, which component of the second heart sound is louder in a normal patient? Yeah, so why? Because it's a high pressure system. So when the pressure goes up in the pulmonary system, the loudness increases for the pulmonary component. So when do you say it's louder? So when you say it's louder, it's usually compared with some other sound. So how do you say it's louder So how do you say it's loud? How do you say P2 is loud? And if you, okay, before this, how do you say P2 is loud is you find out if you don't know, and in which condition P2 is heard in apex without pulmonary hypertension. These three clinical conditions I want you to remember. So it's frequently asked in clinics. That's why I wanted to emphasize on that. So other than pulmonary loud P2, ejection systolic murmur or a mid systolic murmur because of the flow acceleration, and an ejection systolic vascular click. It's a vascular click. It's not a valvular click. I want to ask other things. Where else the valvular click can happen in the pulmonary side? Okay, so the other features clinically would be a left parasternal lift, right ventricular S4 can be present in 35 to 40% of patients, and increased jugular A waves. So other clinical signs that you look for to characterize clinically between a moderate or a severe and advanced pulmonary hypertension, you have to look for other features. So when a severe TR is present, and features of severe TR like prominent CV waves or pulsatile liver, or patient presents to you with ascites in pedal edema, it is said to be in advanced, it is an advanced stage of pulmonary hypertension. So after symptoms and signs, moving on to diagnosis, as we have said, like when you had a clinical suspicion of pulmonary hypertension, we move on to look for signs and symptoms. And for most and first objective should be early diagnosis of the pulmonary hypertension. And second would be the digging down for diagnosis of associated condition which is causing the pulmonary hypertension and treating them, especially in group 2 and group 3 cases. And finding out the associated comorbidities, because it's very important for risk stratification of those patients and guiding the treatment. So what are the ECG features that you routinely see in an well-established pulmonary hypertension, which may not be usually seen in all cases? P pulmonale is defined as more than 2.5 mm P wave in the lead 2 or lead 3 AVF or right axis deviation as noted in this ECG. You can see that. How do you say axis in an ECG?
Two perpendicular lines.
The isoelectric and perpendicular to it. So, or you can see that which is the predominant wave in this infialis. It is more towards the axis, more towards that. And you can see RV strain pattern. So when RV strain pattern is present in, usually it is present in advanced. When you note an RV strain pattern in ECG in a case of pulmonary hypertension, usually a advanced pulmonary hypertension. Pulmonary hypertension can present with prolonged QTC. If retrospectively for a pulmonary hypertension patient, if you find a prolonged QTC, usually non-specific, but if it is there, it may reflect RV dysfunction and advanced stage of RV failure. And it indicates it is a poor predictor of mortality. It's a poor factor for mortality. Radiographic features, as you note in this classical X-ray for pulmonary hypertension, you can see the RV apex nicely. It's an elevated cardiac apex, which is not seen in left ventricular hypertrophy. It will be a down-facing thing. Enlarged right atrium. How do you say enlarged right atrium in a chest X-ray peer view? You put a central line through the spine and measure if it is more than 5.5, if the outer border in the right side, if it is more than 5.5 centimeter, you call it as right atrial enlargement. There are other features you can read about it. It's not very obvious here, but you can see other features like pulmonary arterial dilatation. The pulmonary bay is dilated, prominent pulmonary outflow tract, enlarged pulmonary arteries. You can see right descending pulmonary arteries enlarged, and you can see divide this lung into three parts. The outer 1/3 will be of without any vascular markings, is what polypruning of peripheral pulmonary artery means. So what else you can see? Mainly pulmonary, mainly X-ray is not done in a case of pulmonary hypertension. By the time you do X-ray, you will know the probable diagnosis of pulmonary hypertension. But this to rule out other causes, find out the underlying causes like bony abnormalities like kyphoscoliosis, or find out the features of left-sided heart diseases like left-sided heart disease or interstitial lung disease. So it serves the purpose to find out the underlying cause of pulmonary hypertension. Moving on to echo, those who are familiar with echo can can easily identify all those things that we have put up in this slide. But if you are new to this, you can initially start looking at this. Usually we will look at the pressures only, but start looking at the velocities. TR velocities is what we are first looking at when you have a probability, when you think about the pulmonary hypertension. It is less than 2.8 without any other features suggestive of pulmonary hypertension. It is less likely to be a pulmonary hypertension case. If you find any other features, pulmonary tricuspid registration velocity can be spuriously low in few conditions. If there is other features of, like that what you have shown in this slide, like RV-LV basal diameter ratio of more than 1. Basically, the RV is very much dilated and it's bigger than the LV. That's what it says. And flattening of the intraventricular septum towards and bowing of intraventricular septum towards left ventricle. Basically, the pressure on the right side is going up. That's why it's bowing towards the left ventricle. And the ratio of a TAPC by systolic pulmonary artery pressure, it's a newly coming up criteria. If it is less than 0.55 mm per millimeters of mercury, it indicates pulmonary hypertension. For a pulmonary artery, in a short axis view, if the pulmonary artery diameter is greater than the diameter of the aorta, or if the pulmonary artery diameter measured in the short axis view, it is more than 25 mm, it indicates pulmonary it can point towards pulmonary hypertension. And then IVC and right atrial. Right atrial, we measure the right atrial area. If it is more than 18 centimeters square or IVC is full and not varying with respiration, then it can indicate pulmonary hypertension. Putting together, the probability can be high, intermediate, or low. When do we use CT? So basically, CT is to not to diagnose pulmonary hypertension, but to find out the other causes, any other causes of pulmonary hypertension, like extracardiac causes, like if there is any lung features that can indicate pulmonary hypertension. So you can see here it's an axial CT done at the level of bifurcation. The main pulmonary artery measure is about 3.4 centimeter. When it is more than 2.9 centimeter, it is indicative of pulmonary hypertension. And enlarged pulmonary trunk measured at the pulmonary artery bifurcation more than 2.9 centimeter is in the background of suspicion of pulmonary hypertension. It points towards pulmonary hypertension. Main pulmonary artery to ascending aorta ratio more than 1. It indicates that pulmonary artery is dilated, and with other features of pulmonary hypertension, it indicates pulmonary artery hypertension. Usually the ratio will be less than 1. So right in the next slide, if you can see that the RV is thickened, right ventricular hypertrophy more than 4 mm, and you can see that this is where the intraventricular septum is bowing towards the LV. This is the RV, this is the LV, and you can see the intraventricular septum is bowing towards the RV. So that indicates increased pressure in the right ventricle, and right ventricular dilatation, size of the right ventricle, you can see it is bigger than the LV. So all these are pointing towards, in the background of other clinical signs and symptoms, point towards pulmonary hypertension. So you can see here, the white things are the mural calcifications that are noted in the main pulmonary artery immediately after bifurcation. It is mainly seen in cases of, some of the cases, just to highlight, this is mainly seen in cases with the Eisenmenger phenomenon. So in a VSD, untreated VSD going on for Eisenmengerization can have these mural thrombus. There are some specific conditions where they are present pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis, some of the conditions which present as pulmonary hypertension, but the pulmonary arterial hypertension, but the pathology is beyond the capillaries. So veno-occlusive diseases in CT will have classical features suggestive of volume over, like diffuse ground glass opacities, thickening of interlobular septa. Even the MS patient can have these features. But in the setting of absent left heart diseases, when you suspect pulmonary veno-occlusive diseases, CT will help you to find out these findings. Pulmonary capillary hemangiomatosis suggested by diffuse bilateral thickening of interlobular septa. Again, this is very important. Centrilobular opacities are more commonly seen in hemangiomatosis cases. This is just to point out where CT will be useful in diagnosing the specific conditions for pulmonary arterial hypertension. Other miscellaneous tests at our disposal will be ventilation perfusion mismatch scan, which can be a planar or a SPECT scan. It is mainly used for it's a gold standard diagnostic test for CT-EPH, chronic thromboembolic pulmonary phenomenon, pulmonary hypertension. But we rarely use it because most of the patients will end up with an indeterminate scan. but if properly done, unmatched perfusion defects noted in a CT-EPH is gold standard for diagnosis of CT-EPH. So other tests, pulmonary function test, important for initial diagnosis. Even in the group 1 class, you have to document a pulmonary function test at the initial stages of risk stratification. Especially will be useful in group 3 cases. CPET is mainly useful for if at all it can, if it is to be done in a patient where very obese patient, if you want to assess, find out the cause between cardiac or pulmonary or deconditioning, CPT will be useful. On specific conditions like planning for a lung transplant or a renal, cardiac transplant, CPT is very useful. So as we have discussed before, right heart catheterization is most important for diagnosis of pulmonary hypertension. At least once at the initial diagnosis has to be done. It is gold standard for diagnosing and classifying pulmonary hypertension. Other indications would be in evaluation of a transplant. And most important use of right heart catheterization would be in a shunt lesion. So the classical age of presentation for an ASD would be around 30 to 40 years. And VSD would be a little earlier, PDA will be a bit earlier. So when those patients, when they present to you, we want to have, you want to achieve, you want to device close it, or you want to send them for a surgical closure. Right heart catheterization is very important to assess pulmonary vascular resistance. If at all it raised, reversibility has to be seen. So we do routinely right heart catheterization mainly for these kind of cases. So these are some of the parameters I just put forward here to be familiarized with. When you do, not everything we'll do right atrial, pulmonary artery pressure, diastolic, mean wedge pressure, cardiac output, venous oxygen saturation. Almost all of these things we do on a routine right heart catheterization. So what is vasoreactivity? Certain group of patients in class 1 or in very few number of patients in other groups, they are reactive. That means the pulmonary pressure drops down to a significant level when they were given certain drugs like nitric oxide, iloprost, or an ipoprostenol. These are the approved drugs for this thing, but we routinely do in our practice with 100% oxygen for 10 minutes for vasoreactivity. So this means that if a patient is considered positive for vasoreactive response, when there is a reduction of mean pulmonary artery pressure to more than 10 millimeter of mercury to reach an absolute value less than 40 millimeters of mercury with an increased or unchanged cardiac output. So basically take femoral venous puncture, go across the pulmonary right ventricle, right atrium, right ventricle, enter into the pulmonary artery, leave a catheter there, and we measure the pressures. So when we go up, we take samples from IVC, SVC, RA, RV, pulmonary artery that we use for calculation of all those things. We take samples from there, we derive the saturations. From the saturations using calculations, we derive the pressures and the outputs. So we administer 10%, 100% oxygen for 10 minutes. Basically nitric oxide, iloprost or ipoprostenol, the approved drugs. Adenosine was there in the previous recommendation, which was taken off in this thing. So after giving 10 minutes of nitric oxide, you're supposed to supposed to check the blood pressures. If the mean pulmonary artery pressures drop more than 10 millimeter, those are patients said to be vasoreactively positive. What does it mean for the patient? Those patients can be treated with high dose calcium channel blockers. High dose calcium channel blockers meaning amlodipine, dilsum, nifedipine. Amlodipine starting dose would be 5 to 10 milligrams, can go up to 40 milligrams. As you can see, the problem with this thing is very difficult to uptitrate the medication to that much level, and we end up having hypertension and pedal edema as some of the side effects. But most tolerated among the medication would be amlodipine. But the problem is once the patient is vasoreactive to these drugs, it is not definite that the patient will be lifelong responding to CCBs. So it becomes a problem that we have to repeat every next 3 to 6 months. Again, we have to repeat them with right heart catheterization. Make sure the patient are still reactive and continue them on calcium channel blockers. From there on, you have to take it for 6 months at least follow up. And it is only 10% of people in class 1 group who remains reactive to these drugs. And other groups, it is less than 1%, and over period, they tend to lose those reactivity and ultimately end up having the other drugs. So I'll just enlarge this. This is one important thing we see clinically. How does the class 1 group presents to you? Usually a young female in the group of 20 to 30 with history of dyspnea and exertion. And then the saturation won't be that much low. It will be around 93, 94. Why would the saturation can drop in a pulmonary arterial hypertension, idiopathic pulmonary arterial hypertension? Why is the saturation dropping to 90, 92? Essentially, there is no shunt, right? Why should the saturation drop down to that much? You can find out. So in specific cases of class 1 group like scleroderma, the low DLCO can be low. Otherwise, in other cases without idiopathic PH, the DLCO will be normal. Because why I'm quoting about DLCO is when we refer this patient to pulmonary side, they routinely do as a first initial workup. DLCO will be lower in other groups like class 3 groups. If you go to group 2 patients, mostly they present with left-sided lesions, aortic stenosis, mitral stenosis, elderly patient presenting with HFpEF features or an LV dysfunction with pulmonary hypertension. Some of the classes of patients that do present in group 2. Group 3 would be commonly hypoxemic with features of COPD or ILD. The pulmonary function test will be abnormal, DLCO will be very low. So moving on to the last group, if you see here group 4, there can be a history of venous thromboembolism in this patient, and this patient can present straight away to you with features of CTPH without any history of thromboembolism. Relying on the history of thromboembolism is always misleading. So these patients, there is mismatched perfusion defect in scintigraphy, and CT has, that's where this is one of CT pulmonary angiography, contrast enhanced CT of the chest is one of has characteristic finding in CTPH. Mainly the subsegmental arteries gets involved, and there can be fibrotic strands and webs classically reported in those conditions. So if that is found without any like past history of venous thromboembolism, you can think of CTP. Even without his past history, you can think of CTEPH. Moving on to the management. Sorry. So the goal of our management would be early diagnosis, provide symptom relief, improve functional capacity, and then the survival of the patient. Address the underlying cause of hypertension, like treating the left heart failure and lung diseases optimally, and anticoagulating a CTPH patient. Pharmacological therapy is mainly driven towards class 1 groups, and symptomatic benefit in advanced cases with diuretics. Long-term oxygen therapy when the saturation goes down to less than 18 millimeters of mercury. Lifestyle changes, like for a group 1 clinical assessment with WHO functional class is very important. So try to always advisable to group them under a functional class at the initial diagnosis itself. So it's because the follow-up mainly depends upon the functional class, and the treatment also is mainly depend upon their treatment, and follow-up will be mainly depending on the functional class. This is one of the strongest predictor of survival. Worsening functional class is an important alarming indicators of disease progression. And can you find out the difference between NIH class and WHO functional class based on the parameters used? What is it? There is one difference between WHO functional class and NIH class for dyspnea. So what are the things that are taken into account? Dyspnea, fatigue, chest pain, and near syncope. Is what based on WHO functional class is based on. NIH is based on? Yeah. So pH with positive vasoreactivity, you have a patient with idiopathic pH and they are positively reactive to those drugs we discussed. So how are we going to proceed it with? Initiate treatment with CCBs, achieve the maximum dose. Say amlodipine start with 5 to 10 millimeters of 10 milligram, reach up to 40 milligram or a maximum tolerated dose. If the patient gets downgraded from class 3 to class 1 or class 2, and you're able to see the patient in 3 to 6 months, find out a near normal hemodynamics, and if he remains in the class 1 or class 2 with BNP, optimal BNP, follow the patient for 6 to 12 months. If the patient is not responding, then we have to treat it like a routine vasoreactive negative patient, which we are going to see. So if a patient is vasoreactive testing negative, general measures like supervised exercise training, vaccinating them with specific influenza, SARS and Streptococcus pneumonia vaccine, diuretic therapy, as we have said, in advanced heart failures, long-term oxygen therapy, mainly when it goes below 60 millimeters of mercury, and correction of iron status. These are all the supportive measures we advise. And then sort out the patient, divide the patient find out whether they have any features of cardiopulmonary comorbidities, or if the patient has cardiopulmonary comorbidities, and the recommendation is to individualize the therapy, and it is not that we'll see in the further slides. If the patient has cardiopulmonary comorbidities, the patient has to be risk stratified based on the risk strata. Three risk strata. It is a low risk, divided into low risk, intermediate, and high risk. This is based on 1 year mortality risk of those patients when they present with signs of when they present with pulmonary hypertension. This is mainly based on registries like US Reveal 2.0 registries. From that, they have derived this classes of low risk, intermediate, high risk. High risk patients having a risk of more than 20% 1 year mortality, low risk being less than 5% risk of 1 year mortality. So if you can see many other parameters that was used like CPET, MRI, which is not actually done in a routine practice. When they looked into the feature parameters, WHO functional class, 6-minute walk test, and the BNP emerged as a variables with highest predictive value for mortality. So when they try to analyze that, not that every registry patient has all this parameters. Not everybody has an MRI. Not everybody has a right heart cath done. So when they wanted to look out the parameters which are more sensitive in predicting the mortality, they found out WHO functional class, 6-minute walk test, and BNP are the most important parameters that predicted the mortality. So when we want to when we want to risk stratify the patient, it's better always to put down all these things in the initial chart itself, which function class the patient is presented with, what is the first BNP, how much the patient has walked in, and was there any desaturation in the 6-minute walk test. Those are the important things that we want in our follow-up. Those are important for initial stratification and for follow-up also. Once you stratify them, you stratify them low, intermediate, or high. After stratification, then move on to the therapeutic targets. So what are the therapeutic targets that are available for these patients? This is mainly targeted towards the class 1 groups, because whatever the pH therapy that was developed ultimately found to be fruitful only for the class 1 groups. So it was not very much useful in other groups, whereas specific places where they were found to be useful. 3 pathways, endothelin receptor antagonist, and nitric oxide pathway. There are phosphodiesterase inhibitors, prostacyclin analog, and then prostacyclin pathways. Prostacyclin analogs, prostacyclin receptor agonists are used for this therapy. So we have a clinical experience mainly with phosphodiesterase 5 and endothelin receptor antagonist, and sometimes we use soluble guanylate cyclase inhibitors mainly for CTPH patients. Prostacyclin receptor analogs as a third add-on drug for some cases, which are resistant to where the patient still remains in a higher function class with the dual therapy. So this IV, we don't have much experience with this prostacyclin analogs or IV prostacyclin analogs. And mind you, this therapy is very costly. Like the monthly, as you all know, the monthly cost would be around like 6,000, 7,000. So after stratification, the class 1 recommendation is to start dual therapy at the first step. Start an endothelin receptor antagonist with phosphodiesterase inhibitor. Ambition trial studied about ambrisentan with tadalafil, maximum dose of 10 to 40 milligrams target dose. 10 milligram of ambrisentan, 40 milligram of tadalafil. You can start with 520, go up to 1040 based on the response. Initial therapy with 3 drugs was a class 2A recommendation, and the level of evidence is very low. So it is always advisable. Triton study failed to show benefit with initial therapy. So it was downgraded to class 2A. Initially, there was an enthusiasm to start with the triple therapy, but subsequently, it became a class 2 recommendation. Level of evidence is C only. So class 1 recommendation is to start ambrisentan, tadalafil together at 5-10 milligram dose later up titrate. After initial diagnosis of starting the therapy, we have to follow up the patient with a simplified 4-risk strata risk tool. Here you can see only WHO class, 6-minute walk test, BNP, and then points are assigned to each, based on which you classify the patient to low risk, intermediate low, or intermediate high risk. And when in follow-up, if the patient still remains in high risk, then the risk is, the class 1 recommendation is only for a dual therapy. As of now, even when they tried a triple therapy, at the first instance, it was not much beneficial. The cost of therapy goes up very high. After classification of classification into low, intermediate low, and intermediate high risk, again the class 1 recommendation is for the low group, where you continue the dual therapy, and others are all like based on weak evidences. For if the patient remains to be in class 3, then you can add an prostacyclin receptor analog, or switch a phosphodiesterase inhibitor to a soluble guanylate cyclase inhibitor. So Griffon trial is that which assess the safety and efficacy of Selexipag, and target dose they titrated up to 1600 micrograms. Imagine like we start 50 microgram BD, the patient BP drops down to 70, 80. So it is, I have never titrated any patient beyond 200 mics. So the cost of therapy is very high for these drugs. So basically in our practice, we end up with only 2 drugs. And if those patients who remains in the high risk group, or those finally end up as a qualifying for a lung transplant. So treatment of non-vasoreactive patient is only to start them with monotherapy, phosphodiesterase inhibitor therapy. Vasoreactive patient with active comorbidity, say an LV dysfunction is there, or FFPF is there. Those patients, phosphodiesterase 5 inhibitor therapy based on individual patients. It depends upon the response to those therapies, but never start a dual therapy on those patients. Special mention about drug-induced PH, as we had discussed about recently. Few weeks back, we had a patient with dasatinib. After completing a course of therapy, the patient had presented with almost moderate hypertension. By echo-wise, the TR gradient was around 48 to 50. So such patients, it is relevant, find out the relevant exposure to the drug and stop the drug, never restart the drug, follow up the patient for 3 to 6 months should be our advice, unless the patient presents to you with severe pulmonary hypertension, where you have to start medications and follow them up. So most of the time, with stopping the drug resolves the problem. Just to mention about lung transplant criteria, potentially eligible candidates for whom lung transplant might be an option in case of a treatment failure. So intermediate high risk or high risk, or a REVEAL risk score. There is a risk score from this REVEAL registry. If the score is more than 7, despite on optimal medications, what they say is the triple therapy, which we don't often achieve. Progressive disease or recent hospitalization for worsening pH, ending up with right heart failure. These are some of the patients who requires lung transplant as a treatment. So some of the cases we see as a pulmonary hypertension with some other comorbidities, like HIV patient presenting with pulmonary hypertension, how to treat them. Heart is the only treatment. So you start phosphodiesterase therapy, it has more interaction with protease inhibitors. You start ambrisentan, it has more interaction with RTH. So whatever the available drugs has, available pH therapy has got a lot of interaction with heart therapy. It is so heart therapy is the mainstay of treatment in HIV-associated pulmonary hypertension. Portal pulmonary hypertension. This is a liver disease-associated pulmonary hypertension. There is no clinical data available for treatment of those patients with the available pH therapy, but still some registries have tried using single agents, separate agents like phosphodiesterase inhibitors, bosentan, with variable results. So there is no recommendation as of now to use these medications. Liver transplant, if you want to post a patient for a liver transplant, if they have a severe pulmonary hypertension, is where these phosphodiesterase therapies can be used to bring down the pressures to below 36 millimeters of mercury, and you can send them for liver transplant. This is where it has found its usefulness. Adult congenital heart disease is a separate group, and it's an extensive topic. we have to discuss about the various physiologies of pulmonary circulation to better understand these pathologies. But to mention about it, closure of shunt, if the pulmonary vascular resistance is less than 3 in all those vascular and that shunts that I mentioned before, ASD, VSD, PDA, it will alleviate the symptoms of pulmonary hypertension. And more than if there is a raised pulmonary vascular resistance, closure of the shunt is contraindicated. We initially used to treat borderline pulmonary hypertension, initially used to treat those hypertension with medications and then proceed on to closing those shunts with devices, sometimes with fenestrated devices. But those are things which doesn't have any evidence. There's no studies were based on that. It was not based on any studies. And most important thing for these patients, when they present to you, you have to suggest them for a contraception and provide a proper psychosocial support for them. Advise them not to get pregnant. So there are so many Western literatures where patients who are treated stable pulmonary hypertension, not requiring much medication, going on to have pregnancy, getting delivered, doesn't happen in our setting most of the time. It carries high maternal morbidity and even the fetal morbidity. So mortality and morbidity. Routine phlebotomy is not indicated. You might see some patient presenting to you with Eisenmenger syndrome, PDA, VSD, going on for Eisenmenger, presenting with polycythemia. We do only when the hematocrit, despite adequate hydration, if the hematocrit is more than 65 with features of hyperviscosity like headache, breathlessness, all those things. If it is there, you can suggest phlebotomy. Finding out iron deficiency and supplementing them with iron therapy is only important step. There are very few things that we could do for those patients. So vaccinating them for specific organisms. And if such patient presents to you with big thrombus in the pulmonary artery, which is very rare conditions where anticoagulation is indicated in such patients. Bosentan was tried, but the level of evidence is class C. We don't start in those patients mostly on these medications. PH with left heart disease, mostly patients will have valvular heart disease, associated LV dysfunction. They present to you with pulmonary hypertension. One important thing I want to suggest, emphasize on this thing is treating those patients with phosphodiesterase inhibitors is a class 3 recommendation. So we see from outside so many patients refer to us with pulmonary hypertension diagnosis just being on sildenafil. So it will potentially worsen those conditions. Treatment for specific condition is what is needed. There were recent trials like reduced lab2 trials where they tried interatrial shunts. They put a device across the interatrial septum. Initial results were enthusiastic. They were achieving good response, but later benefits were not found. Catheter-based intervention at the earlier stage or valvular replacement surgeries for valvular disease will only alleviate those symptoms. Group 3. See, if you find a patient, based in this slide, I just want to emphasize one thing. If you find a patient with a COPD having severe pulmonary hypertension, it is better to look for other causes of pulmonary hypertension. Those patients very rarely, if you see a Brownwall says, it is very rare to find a patient having pulmonary hypertension, TR gradient going beyond 40, 45, 50 in a COPD patient. So it is prudent to look for other causes in a lung disease having severe pulmonary hypertension. Very 5 to 10% of patients has a PVR of more than 5.5 in these groups. So class 2B recommendation is only given for phosphodiesterase test only when the pulmonary hypertension goes up very high. So it's basically treatment of the underlying condition. We'll end up with this CTPH. Special mention about this is when you want to when you suspect about CTEPH, we don't do perfusion scanning. What we do is we confirm echocardiographically by presence of pulmonary hypertension. We do CTPA, confirm, and we can do digital subtraction angiography in cath lab and right heart catheterization, confirm the diagnosis, and then treat based on the multidisciplinary approach. CTPH requires lifelong therapeutic anticoagulation. Again, the debate is between a vitamin K antagonist or a NOAC. So NOACs in registry is found to have increased bleeding risk, and these CTPH patients, 10% of those patients have APLA. So it's better to be to keep those patients on vitamin K antagonist. There are certain subset of patients who may benefit from interventional therapies. So if you see here, if the fibrotic bands or a thrombus found in a proximal artery, you can send them for a endarterectomy. It is a possible surgery where they open up the main proximal arteries and remove those thrombus. If it is found in subsegmental arteries, we can essentially go in and do a balloon pulmonary angioplasty and relieve of those obstructions. And if it's microvascular, nothing much we could do interventionally. So it's all medical therapy. So CTPH has, we have to find out which subset this patient belongs to provide the best possible therapy. Follow-up would be for at least 3 to 6 months. For vasoreactive patients, we have to redo the right heart catheterization. For other patients, at least the basic things like functional class, BNP, 6-minute walk test, and how much they walked, how much the saturation was achieved, and echocardiography, finding out the RV strain, finding out the right atrial volume, all that matters in follow-up. And risk, if the patient is found to be in higher class, uptitrate the medication. The maximum we could do in our setting is to uptitrate the medication, add on diuretic therapy if the patient goes in for ALE failure. Unfortunately, still the therapy is very costly for all this idiopathic pulmonary hypertension. I hope in some coming years, if the cost of the therapy comes down, more number of patients might get benefited. Pulmonary hypertension, so far, I don't think, I was thinking before my tenure in cardiology, I was thinking it is always used to be a specialist disease. So whenever I find pulmonary hypertension, I used to push it to cardiology or pulmonology. So it's always a multidisciplinary when a physician can effectively treat a pulmonary hypertension with few contributions from the specialist. So where specialist intervention needed like CTPH, or doing a simple right heart catheterization would be our maximum contribution. So rest of the things are all based on guidelines. Thank you for patient listening. If there is any questions, I would like to answer. What's the time now? 2:30. So many other things that I didn't focus upon, like the adult congenital heart disease itself is a separate topic. So going into detail about those, it's very difficult to, and it's very monotonous, no? It's discussing about.
Any questions from the audience?
So at least by the end of thing, if you find out the answers for all those clinical questions that are asked, it will be useful for your clinical exam. Those are the basic things. If you think now, you would have been telling P2 loud for longer time. Maybe knowing, not knowing, you would have forgot, but just brush up those things, it will be useful.
Thank you, Dr. Sakthivel, for that lecture. Thank you all for joining us. Next week, we don't have a lecture in New York for medicine and modules, so we'll have a lecture following. Thank you so much.
So I think most of you will have my numbers. So if there is anything to improve on, cut short the duration of therapy, hopefully I'll be able to do it next time. You can feel free to suggest those things. Thank you.